Hello, my name is Scott Oppenborn. For my final literature summary, I chose to do it on catheter-associated urinary tract infections and methods to reduce them. I chose to reduce CAUTI because my grandmother developed a UTI from a catheter when she was in the hospital, and that caused her to develop sepsis. Seeing her go through that was very tough on me, knowing that it could have been prevented with a little more care. Reducing CAUTIs is important to the public because, according to the CDC in 2015, among UTIs acquired in the hospital, approximately 75% are associated with a urinary catheter, which is a tube inserted into the bladder through the urethra to drain urine. Between 15 to 25% of hospitalized patients receive urinary catheters during their hospital stay. It is important to the healthcare system because they are the most commonly reported healthcare-acquired condition. More than 560,000 patients develop CAUTI each year, leading to extended hospital stays, increased healthcare costs, and patient morbidity and mortality. It is important to the patients because they are already in the hospital for something they are not happy about, and to put more stress on them with an infection that can be prevented is something that the healthcare organizations should strive to change. The PCOT statement I chose was a population, patients over 46 with indwelling catheters in critical care, the intervention being daily cleansing of the urethral meatus using soap and water or perineal cleanser, the comparison, not cleaning the catheter or meatus at all, the outcome, reduce the number of catheter-associated UTIs, and the time being over 5 months. So, for patients over 46 with an indwelling catheter in critical care, does daily cleansing of the urethral meatus using soap and water or perineal cleanser, compared to not cleaning the tube or meatus at all, reduce the number of catheter-associated urinary tract infections over a 5-month period? In my search for 5 articles, I used a few databases. The first one being Cochrane Library. The search term I used was urinary catheters, and that yielded 452 results. I tried narrowing it down and used the limiters protocol, review, and Cochrane evidence. That yielded 472 new results, even more than the first time. Since that still had too many results, I used the ECRI Guidelines Trust database, where I typed in urinary tract infections, and I narrowed it down using age 46 to 80 and older, and from 2018. That brought me down to 4 results. The final database I used, where I ultimately found all 5 of my articles, was the CIN-AHL Complete. The Boolean operators used were catheters and UTIs and cleaning. That yielded 332 results, so I narrowed it down with the limiters and expanders of abstract, peer review, English language, and age 46 to 80. That brought me to 38 results where I found my articles. There was a method for the selection of the articles that I found. The articles selected were all different levels of evidence-based practice. They were all also up to date within the last 10 years, which is very important because as times change, technology changes, and evidence changes, so it's imperative to stay up to date. Research was also done in different parts of the world, which is interesting because in some parts of the world you see different populations where tools are not as easy to get to them. So seeing how CAUTI rates in those parts of the world was quite interesting. Randomized and non-randomized controlled studies were used in the evidence, and all of the authors were reliable and validated. Throughout the 5 articles, there were a lot of similarities between them. In the Miller study in 2018, They aimed to see if implemented measures would reduce the amount of catheter-induced urinary tract infections. Also, like the CROSS study in 2019, they identified ways that nursing staff could support catheterized patients to maintain effective catheter care to reduce CAUTI rates. In the Ketchum study in 2010, study participants were in the trauma wings of the hospitals, which was the population in my PCOT statement. In each study, they were in the trauma wings as well. Another similarity was that the studies were all done in one hospital. So granted it was limited, but it was consistent. They were all done in one hospital. It wasn't the same hospital, but they were all done in one hospital. With there being some similarities, there were also some inconsistencies in the studies. In the CROSS study in 2019, it stated that findings within that study may have been influenced by publication bias. In the Ketchum study, subjectivity was involved in the daily evaluation of the appropriateness of catheter use, and that meant that when a difference of opinion occurred, the evaluators gave the most weight of judgment to the nurses who were providing the direct patient care. So there was also a little bit of bias because it was that nurse that was providing the care's decision. In the Groves study in 2019 in Nepal, some perceived barriers was the inaccessibility of toilets, 73%, and the difficulties obtaining supplies, 72%. So there could have been some inconsistencies there with CAUTI rates because they did not have good enough supplies or toilets. Each article that I found also had some gaps and limitations. In the Miller study in 2018, it was conducted at a single facility, and although implementation was hospital-wide, the intervention was only measured in the trauma population. Also, multiple interventions were implemented as a bundle with ongoing evaluation and quality improvement, dictating application of resources and further interventions. In 2010, in the Ketchum study, they did not have accurate information in the period before the intervention to calculate mean duration of catheterization. Therefore, they could not make any conclusions about any effect of the duration of catheterization. In the CROSS study, the inclusion and exclusion criteria placed limitations on the types of studies retrieved and considered appropriate for that review. That may have led to some relevant studies being overlooked. And it must also be acknowledged that the findings within the studies selected may have been influenced by publication bias. In the Grove study in Nepal, the sample was small and limited to 5 districts. Therefore, the results may not be generalized to the overall practice, but just among the people in Nepal. After finding evidence for this project, I think I can conclude that there is enough evidence to support a practice change. In the Miller study in 2018, execution of the 5S CAUTI bundle, which was the 5 implemented measures to reduce catheter-associated UTIs, resulted in a significant 80% reduction rate in the trauma population. That's a big number. With use of guidelines, in the Ketchum study in 2010, duration of use was significantly reduced to a mean of 238.6 from the previous rate of 311.7. The number of catheter-associated urinary tract infections per 1,000 days of use was a mean of 4.7 a month before the intervention and 0 during the 6-month intervention. 0. The cleansing of catheters on a daily basis would show a major drop in the amount of catheter-induced urinary tract infections. If nurses and doctors pay more attention to catheters and being able to notice if there's dirt or stuff on there that needs to be cleaned, that will save nurses time, that will save the hospital's money, and that will save patients time that they have to stay in that hospital. So I conclude that there is enough evidence to support a practice change.